Welcome to the Emergency Medical Treatment and Labor Act presentation, or the EMTLA, TALA presentation by Madison Burris, Sarah Huth, and Jen Robinson. A little history behind the EMTALA. In the early 1980s, there were dreadful stories about patient dumping, which is the practice of refusing emergency treatment due to a patient's lack of insurance or ability to pay, were rampant. Some hospital emergency departments and physicians were refusing to treat patients in an active emergency. Some only examined patients before transferring them in medically unstable conditions to public hospitals. Congress responded to this patient dumping in 1986 by enacting the Emergency Medical Treatment and Active Labor Act, or the EMTLA. This is to ensure public access to emergency services regardless of a person's ability to pay. While EMTLA did not address the cause of uncompensated care, it did guarantee universal emergency access for all. Congress required healthcare providers to assume fiscal responsibility for the emergency care of the indigent and the uninsured. Refusing such treatment based on payment status could result in punitive fines, civil liability, or loss of participation in Medicare and Medicaid programs. So essentially, the law was created a federal right to emergency care to anyone in the United States. The act was a mere 4 pages tucked into a miscellaneous section of a giant 2,200 plus page omnibus bill. So the Center for Medicare and Medicaid Services, or CMS, the agency that was charged with drafting the EMTLA rules for hospitals and enforcing those laws, took about nearly 10 years to form the initial regulations. Now, since then, they've evolved and they've changed. They've done surveys, they've created new guidelines. And the law itself was also amended a few times over the last 10 years, but most meaningfully in 1989. To require our country's more capable hospitals to accept unstable patients in transfer from the emergency departments of less capable hospitals. If they had the capacity to stabilize the patient's emergency condition, previously tertiary hospitals refused to accept emergency department transfers, even on dying patients, unless payment was assured in advance. Branded as reverse dumping. So it was kind of counterintuitive. So the Office of the Inspector General can impose civil monetary penalties upon hospitals and physicians for EMTLA violations, or terminate a physician from Medicare qualifications. Congress recently more than doubled the amount of potential fines to almost $105,000 per violation, and set the amount to increase annually by an inflation factor. They originally wanted physicians to pay $250,000 in fines and spend 5 years in for violating the law. So there was definitely a compromise. It fortified emergency physicians to remain steadfast in providing emergency care to all, to anyone, anywhere, at any time. Emergency physicians have also learned how to use the law to advocate for patients. Under the force of the EMTLA, they can determine pre-authorization requirements. They can triage out practices and other limits on access to emergency care imposed by insurers or managed care companies. More immediately, EMTLA has also improved the behavior of emergency physicians transferring patients, and those physicians accepting transfers on behalf of higher level hospitals. Invoking the EMTALA to demand appropriate responses from on-call physicians is another everyday example of the law's usefulness in advocating for such patients. So, EMTALA, according to the law, EMTALA applies when an individual comes to an emergency department. The Center for Medicaid and Medicare Services defines a dedicated emergency department as a specially equipped and staffed area of the hospital used as a significant portion of the time for initial evaluation and treatment of outpatients for emergency medical conditions. So to sum that up, this means, for example, that a hospital-based outpatient clinic not equipped to handle medical emergencies are not obligated under EMTALA and can simply refer patients to a nearby emergency department for care, and they must be accepted.
According to the American Academy of Emergency Medicine, EMTALA was promulgated to combat the discriminatory practice of some hospitals transferring, discharging, or refusing to treat indigent patients that were coming to emergency department because of high costs associated with diagnosing and treating these patients with emergency medical conditions. Some people aren't able to afford emergency services because of the high cost. As a result of EMTALA, public access to these services are ensured for all. Violations of EMTALA are complaint-driven and are usually reported to the Department of Justice or the Department of Health and Human Services Office when it comes to civil rights. Those hospitals and physicians that comply with the Emergency Medical Treatment and Active Labor Act all have protection under the same statute. If they fail to comply, they can face civil enforcement and monetary penalties because the hospital is directly liable for any harm that is done to the patient by any violations of the law by the staff or physicians. Hospitals are more liable. Each investigation of the hospital's policies and procedures are initiated by the complaint. If the complaint investigation is valid, then a hospital may be terminated from its provider's agreement or imposition of its civil monetary penalty. Investigative procedures in order to even be eligible to violate EMTALA, the facility has to meet the following requirements. They have to be licensed by the state, held out to the public as a place that provides emergency care, and provide at least 1/3 of visits on an urgent basis. When a complaint is received, the facility will receive an unannounced investigation. Investigators will look at rules and regulations of the medical staff, board meeting minutes, physicians on call list, quality assessments and performance improvement plans, emergency department personal records, ambulance trip reports, and other documentation relating to emergency care procedures. They look at a sample size of 20 to 50 cases with the nationality, diagnosis, gender, and patterns related to those specific minorities. The investigator conducts additional record reviews and personal interviews. Then the investigator will conduct an assessment of compliance and completion of deficiency report. Hospitals with dedicated emergency departments are required to take the following measures. They have to adopt and enforce policies and procedures to comply with the requirements of the number 42 in CFR section 489-24. They have to post signs in the emergency department specifying individual rights maintain medical and other documents related to individuals transferred to and from the hospital, maintain a list of physicians who can provide the treatment, maintain a central log of individuals coming to the emergency room to receive the treatment, and provide care like medical screenings and appropriate transfers.
In October of 2018, research was published that looked into hospital violations of the EMTALA. The research team examined monetary fines received from hospitals during 2002 to 2015. The results showed that settlements from EMTALA violations decreased from a high of 46 in 2002 to a low of 6 in 2015, which is a decline of 87%. Settlements resulting from violations most commonly occurred for failure to screen and failure to stabilize patients in need of emergency care. The research additionally determined that EMTALA violations are more likely to occur when the financial liability of a facility is threatened. And here's the table that shows the year and the number of violations and some of the potential hospital statistics related to the EMTALA. And this is a distribution by state for the average fines during that same time period, 2002 to 2015. Sorry for the blurry image, but in the research paper, the image was blurry. So we know that the Office of the Inspector General is at the federal level, and they receive the complaint of a violation. So what does the state have to do with it? The State Department of Health and Welfare is there to help facilities to be proactive and be compliant. In Idaho, the Health and Welfare Department has published different documents, including transfer checklists, transfer orders. They have an interfacility transfer tree or decision tree, and they have ground risk matrix. The ground risk matrix is this document here that shows if it's safe to transport a patient or if they should stay at the facility, because the number one thing of importance is patient care and patient safety. So documentation is key to keep a facility safe and not be in danger of violating the act. And then some facilities can use this decision tree to decide if they should keep a patient or need to transfer a patient based on their liability according to EMTALA. And here are our resources that we used, and we hope that you have a better understanding of the Emergency Medical Treatment and Active Labor Act. And thanks for listening.